Good afternoon again. I will try to finish it up and give at least 15 minutes for question and answers because I expect there would be some. There are no conflicts of interest which we need to declare here. The overview would be I'll cover it under the headings of introduction, when to test, what to test, how to interpret results, when to order confirmatory test, and what to do if test is positive. In this series, we are taking topics which are clinically oriented, so I won't be dwelling much into evidence and things like that. So just to sensitize you, this is a case scenario which I had come across a few days back in OPD. This is a 36-year-old male with past history of treatment for ADS, currently on treatment for chronic pancreatitis, and he is referred by a gastroenterologist for so-called aberrant behavior because he is continuously asking to increase the dose of the pentazocine injection that he is on. Physician is actually concerned about diversion. He did not pen it down, but he spoke to me personally and said it over phone. There's occasional alcohol consumption, which patient agrees to, and there's consumption of sleeping pills occasionally. I have summarized what I found after the interview. So he was on pantoprazole and zolpidem, which were prescribed medications, and the last use was about 12 hours back. Heroin he had bought off the street at one point of time, about 1 week back he used it. Codeine he had used as a cough syrup 2 weeks back. Injection pentazocine again prescribed about 2 hours back. Alcohol 72 hours back. Cannabis he said he has never used in his life. And he had taken tablet lorazepam 8 mg. This was not prescribed. He had taken it from pharmacy about 12 hours back. So screening UDT was done, and opioids, the result came negative. Benzodiazepines, the result came negative, and cannabis, it came to be positive. Now, just jot down your thoughts or make a mental note if you can. Some of the questions here are: opioids are negative, so is he actually diverting pentazocine? Benzodiazepines are also negative, but then he says he has taken lorazepam. Why would somebody lie about that? And cannabis has turned out to be positive, which patient did not agree to. One can fly off the handle and believe that patient is grossly misleading the whole team, but at the end of this, I'm going to tell you how it is not the case. Coming to introduction, briefly about why are we discussing this topic today. One of the things is it provides an objective measure of recent use of substances. I mean, as much as a good history is very useful and frequently leads to a diagnosis, this is an objective measure which can be recorded, followed up, which can be reproduced, and which cannot be contested. Increasingly used in chronic pain treatment. This is an area which is actually picking up significantly, but I'm not going to cover it in this discussion. It's mandatory in some countries for patients on methadone maintenance and buprenorphine maintenance. In fact, the outcome of an ongoing replacement program is the number of urine samples which were submitted in a given period and turned out to be negative. And of course, it's important in legal and quasi-legal situations. So why urine drug screen? Why do we prefer urine? One of the things is because it's an excretion ultimately, it has an increased window of detection as compared to blood. Typically, this window is about 1 to 3 days for most drugs and or their metabolites. It is less costly than serum testing because probably the extraction is easier. It is certainly less invasive. One of the main drawbacks is sample integrity, and this is going to be a topic that I will discuss in some detail. I want you to conceptualize drug testing as patient-centered testing. I mean, that's how I and the extant literature conceptualizes it. Patient-centered testing and non-patient-centered testing. It's quite easy. When the drug test is being done to help the patient, it's patient-centered testing. When the drug test is being done for anything other than helping the patient, then it's a non-patient-centered testing. So examples of patient-centered testing could be evaluation and management of substance use disorder, in emergency settings, both medical and psychiatric, during agonist maintenance treatment, high-risk situations like pregnancy, HIV and HCV treatment clinics, and chronic pain treatment. Non-patient-centered testings can mostly come down to forensic settings and para-forensic settings. They are quite different, both scientifically and from a sociological point of view. The main difference which I think is non-patient-centered testing most of the times can have a punitive consequence if it turns out to be positive, while that is not the case in patient-centered testing, because the whole idea of patient-centered testing is to help with diagnosis and management. Some of the other factors is the possibility or the pre-test probability, what we call, of getting a positive result in a population which is known to use is certainly higher. So therefore, you would want to keep lower cutoffs. Whereas it is lower when you go out in military establishments or sports facilities. So you would want to keep a higher cutoff because you do not want false positive reactions there. Patient-centered testing is consensual. Non-patient-centered testing may be non-consensual under some circumstances. As I said, patient-centered testing should not lead to punitive consequences, while non-patient-centered testing mostly does lead to punitive consequences. In patient-centered testing, since it is not forensic in its use, due process rights, chain of custody, when was the sample obtained, who had it, and then all that paper trail is not that important in patient-centered testing. Of course, sample integrity is, but probably the paper trail is not that important. Whereas for non-patient-centered testing, you require forensic standards, just like you handle any other piece of evidence. Another way of conceptualizing types of tests are point of care tests, basically bedside tests, which can be done with minimum equipment and give result then and there itself. Most of these point of care tests are competitive immunoassay procedure based. They are cheap, they are rapid, they do not require sophisticated instruments. The only problem is they are qualitative. So there are arbitrary cutoffs which have been decided by various organizations, which you will have to refer in the package insert of the test which you are using. Confirmatory tests are advanced tests for detection of the specific molecule which is present there. It's a combination of a separation technique and then detection of what you have separated. It certainly requires sophisticated instruments and quite some amount of technical expertise, and it gives you a quantitative value. I'm going to limit my presentation to patient-centered tests and that to point-of-care tests, primarily for the reasons because I think most of our partners would be able to do it. Now the question is when to test. So it is slightly repetitive. In addiction services, I want to stress that at the level of initial evaluation and follow-up, it is completely okay, it's completely cool to do a urine test. You aren't suspecting the patient. For an example, when you're treating a patient with diabetes mellitus and he tells you he has been taking his insulin and he has been doing all the lifestyle modifications, you still do order for a sugar level. It is not that you are doubting him, but you just want an objective measure. So it does not hurt to do it even in regular cases. Of course, in residential treatment settings, basically to find out is there an ongoing substance use in the population at that point of time. Medication assisted treatment certainly for 2-3 reasons. One is if the test comes out to be positive, person is still using, and that's a reason for you to talk. Your treatment is probably not optimal yet. Another is you might want to consider the risks of diversion or misuse. Another area where it is useful is patient advocacy. Most simply put, you give patient a ground to stand on when he gets a negative test. Medical specialties, tox screen is a very old word. Basically, in emergency settings, somebody is unconscious and you want to find out what has happened. Tox screen is one of the investigations which is ordered. Pain and palliative care, I have already mentioned. Pregnancy and HIV and HCV treatment programs also are increasingly using UPTs at the initial level. In psychiatry, of course, during the screening to find out if there are any comorbid substance use and for differential diagnosis. For example, somebody who has presented with acute psychotic symptoms, finding a positive cannabis test will indicate that you have to go back to the history and find out what the pattern of use was. Coming to the detection window, as a thumb rule for most substances, up to 3 to 5 days is the detection window. Of course, it varies for different substances and for different tests depending on their sensitivity, except for marijuana and benzodiazepines. The main questions that you need to ask yourself is, how fast is the suspected agent metabolized? For example, cocaine does not remain in significant amounts in blood for any measurable period of time. By plasmaesterasis itself, it is metabolized. So for you, that's a very highly metabolized agent which you're talking about. Does your test detect the specific metabolite or only parent molecule? Taking the same example of cocaine, the test you are doing is for cocaine or benzylecgonine. What is the pattern of use and when was the last occasion? Of course, that will say in which window you are. Is there a chance of detecting or not? This is a list of detection window for some of the tests which we do. Alcohol is detectable for 3 to 5 days via EPG and metabolites. Amphetamine, except methamphetamine, for 1 to 2 days. Benzodiazepines, acute or short-term use for 3 days, while chronic use, especially of highly lipophilic agents, for 4 to 6 weeks. Marijuana, light use or occasional use for 2 to 7 days, while prolonged heavy use for up to 1 to 2 months. Cocaine is detectable by its metabolite for up to 2 to 4 days. Morphine is detectable as such for 2 days. Methadone is detectable for around 3 days. Now, what to test? That is, what is the molecule that you should be looking for? And it is all about the pharmacology of the substance that is in question at that given point of time. The whole idea is immunoassays have decided to take one metabolite or intermediate which represent the whole class. For example, morphine is common between heroin and codeine. So morphine has been chosen to detect opioids as such, but then a number of agents are missed, which we are going to discuss. Similarly, oxazepam or nordiazepam are common for a number of benzodiazepines. So ultimately, because these are the actual molecules you are detecting, when we order a test and say a cassette test for benzodiazepines, what we are actually detecting is only oxazepam and nordiazepam probably. So you will get false negative for compounds which do not have this metabolite. For example, fentanyl, methadone, meperidine, buprenorphine, clonazepam, and so on and so forth. It is a very important and quite a big list. Again, the most important question is what are you looking for and what does the test look for? If there's a mismatch between these, then it's quite likely that you'll end up with a false negative. For an example, please make note that most of these arrows are unidirectional. So codeine is converted into morphine, and heroin again via 6-MAM is converted into morphine. So you can find 6-MAM in a patient who has recently used heroin, and it will be specific. 6-MAM is a specific for heroin, while morphine can be present if he has used codeine or heroin either. Whereas there are a number of agents, for example, one is represented here, oxycodone, which does not go through this cycle. So you will not detect that. So as I said, one has to be mindful of what we are ordering, what is being expected. One of the interesting questions is, can you detect heroin abuse in a patient who is therapeutically on morphine? Actually, unless you get the levels, it is going to be difficult, or unless you can catch him, he has used recently and you detect 6-MAM. These are the only two conditions because morphine is a metabolite of heroin. Coming briefly to benzodiazepines, most of the benzodiazepines that we of late see, say alprazolam, lorazepam, or clonazepam, they do not go through these steps. Some of them are nitro-reduced, some of them are converted into conjugates directly. So a screen for benzodiazepines, so-called screen for benzodiazepines, might not detect it. The same goes for flunitrazepam and nitrazepam as well. Coming to THC, the only important part on this slide is what we are detecting is COOH. It's basically an acid which we are detecting, which is not active, which is not psychotropically active. So finding it positive when somebody is not having any symptoms of intoxication should not baffle you, because you're basically detecting a metabolite. You're not detecting the psychotropically active molecule. Coming to the next question, how to test. Choice of method, I believe, is majorly guided by available resources. If cassette test is all that can be procured in a given setting, that is all that one can do. First test can usually be a point of care immunoassay test. No point of care tests, immunoassay tests at least, are as of now, I believe, available for synthetic cannabinoids, GHB, solvents, and synthetic opioids. The essential steps of doing the test is, number one, sample integrity check, which I will discuss in detail. You have to add the specimen in the given well. You have to wait for 5 minutes, not longer, because it slowly disintegrates and you might not get a valid result. And then you interpret the result. The first thing is make sure it is urine, and then make sure it is patient's urine. So the dilution can be checked by basically checking the specific gravity. Specific gravity is mostly available in most of the labs. It is available. You can check that. Simple measures to maintain sample integrity is, if possible, samples can be collected in clinic. Attender can be asked to hand over the sample after collection. This decreases the chance of giving another person's sample. And the testing routine should be random rather than predictable for the patient. These are some things which can reduce. But the point remains that direct observation of a urine sample collection is difficult, and hence there is increasing discussion about saliva and other samples being used for detection of substances. Coming to sample integrity, temperature within 5 minutes, if the volume is from 30 to 50 ml, falls to about 90 to 100 degree Fahrenheit. Specific gravity is more than or equal to 1.003. If it is lower than that, then probably the person has mixed some water or some other liquid, transparent liquid in it. pH is generally varies from 4.5 to 8. One of the useful tests is creatinine. Greater than 20 mg per deciliter it means it's a good sample. 5 to 10, it is possible that patient has tried to take a lot of water before giving the urine, or has added water from outside, or he has a renal disease and he cannot concentrate it, and he has a concentration defect. But less than 5 mg per deciliter is certainly not human urine. No matter how much water somebody takes, it cannot go lower than this. How to interpret results? Okay, this is repetition. Basically, same questions. What are you looking for? What does your test detect? And is there a mismatch? Now, the results are slightly counterintuitive. Presence of line is negative. We are attuned to presence of line being positive, and for a comparison, I have put a pregnancy test there. So presence of two lines, both control and test, is read as a negative test, whereas absence of the test line is read as a positive test. If you do not have confirmatory tests at your place available, I think one of the things which can be useful is history. You can filter the result of your point of care test through the history. So if you've got a positive result and the history is also corroborative, you can tentatively believe it is true positive. I mean, it's not the right use of that word unless you do another test, but you can believe it is true positive. If possible, you can confirm that. But if you've got a positive and the history is completely non-corroborative, it's probably a false positive. You will have to review for cross-reactivity and rule out the same. And if possible, you confirm the test. Again, for negative, if it's corroborative, you can say it is true negative. You can continue random testing at different intervals. If it's non-corroborative, then there's a question of false negative. First thing that should click is sample integrity. You might want to retest it in a higher facility at the limits of detection, because the thresholds of different tests are pretty high. And you must sit down and review what you had tested and was your test powered to detect it. Coming to false positives, the main consideration is in false positive is cross-reactivity. Because it's an immune-based test, there are chances that molecules with similar structure or sometimes completely unrelated structure can also interfere or change the test. So from the data that is available, the highest positive predicting value is for benzyl for cocaine. There are hardly any substances which are reported which cross-react or interfere with it. THC has about a positive predictive value of 92.2%. Opioids are 71.2. Lowest is for amphetamines. Somehow we do not deal a lot with them, but once somebody goes into amphetamine testing, it becomes quite difficult. There are different stereoisomers. Only one of them is CNS selective. It is difficult to separate them, things like that. But as you can see, most of them positive predictive value is quite high. So these are quite robust tests, one can say, if they are used mindfully. Always review patient's medication and consult extant literature if cross-reactivity is suspected. Some of the common cross-reactivities I have mentioned here. Cannabinoids, dronabinol does react, nabilon does not. Efavirenz gives a positive reaction for cannabinoids, and some of the PPIs give. There are reports for pantoprazole especially, but omeprazole also has been mentioned. For opioids, dextromethorphan, because of similarity of structure. Rifampin, there are case reports, but no good quality data. Quinolones, again some case report. Benzodiazepines, sertraline can at times give a positive reaction, result. Stimulants, as I said, selegiline, L-isomers, chlorpromazine, methylphenidate, and a number of other drugs. Benzyl, as I said, none. The cutoffs which we follow right now for POC at our center, and I want to stress it again, that every drug detection device comes with a package insert and the cutoffs are mentioned in it, and it can vary. So one will have to read from that literature. For opioids, currently we are using 300 nanograms per ml of morphine, which is much lower than the SAMHSA standard, which happens to be 2000 nanograms, because that is meant for forensic and paralegal purposes. And one does not want to risk somebody's career or probably a jail term based on a false positive reaction. Benzodiazepines, 160 nanogram per ml of diazepam. Cannabinoids, about 50 nanograms per ml of the metabolite. Some of the myths which are quite prevalent among public, especially, are false positives are more common than false negatives. Actually, false negatives are much more common, basically because of drug detection window, and false positives are not that common as we believe them to be. Another is passive inhalation of, say, somebody else is smoking cannabis and you're sitting in the room. Can you have high levels? In 1983, quite an inhumane study was done where volunteers were put in almost a gas chamber and were gassed with THC. Still, the highest level that anybody could get was 20 nanograms per ml. the threshold which at least we are using is 50 nanograms per ml, which is pretty high. So it signifies first hand use. It does not signify second hand use. Various food products can give a false positive test. Hash cookies, of course, will give a positive test for cannabis because you have used cannabis in a form. But does chocolate give false positive for cocaine? No, absolutely not. Do poppy seeds give? Yes, they do. And that was one of the reasons why the threshold in SAMHSA's revision was raised to 2000 nanograms per deciliter. Another is drug tests can be fooled by taking a lot of water before testing. As I said, these drug tests, especially immunoassays, are calibrated to maximum dilution. So it is not possible humanly for somebody to take this much water just before giving a sample. When to order confirmatory tests? The theory says positive test always, of course, if it's available. Basically, to rule out cross reactivity and to say this is a true positive and not a false positive. Identify the exact compound, and of course, to get a quantitative assessment, longitudinally you can review and see are the levels falling, are the levels rising, what is happening with the patient. Negative tests, if the history is highly suggestive, you might want to go for a confirmatory test. If the threshold of your POC is very high, for example, if you are using one of the SAMHSA's sanctioned kits for in India, you might get a false negative for opioid use. In that case, you might want to go for a confirmatory test. And of course, in quasi-legal scenarios. Indeterminate tests, always you should go for a confirmatory test or a repetition of the first test. Briefly about what to do if a point of care test is positive. Certainly order a confirmatory test if that's available at your center. Please rule out false positives, sit with the patient, note down the medicine he is on, rule out any cross reactivity. More important parts is use this as an opportunity to initiate discussion. So something is going on which you do not know and which patient has not agreed to. So of course it calls for a discussion. Do not make it punitive because it is not going to serve a purpose. Revise the agreement and therapeutic alliance, especially in agonist maintenance. If patient continues to give positive samples, you might want to review the dose of medicine that you are giving to that extent. Whereas it appears counterintuitive, the natural affinities towards believing my treatment is not working, I need to stop this. What is the point of giving an agonist? But there are studies which have said when you increase or when you shift from buprenorphine to methadone, the same people who were giving positive samples till now start giving negative samples, and continue random tests in future as well. So coming back to the case which I discussed in the beginning, this is just to revise. So he is on pantoprazole and zolpidem. He is also on pentazocine. Heroin, codeine have been used 1 week and 2 weeks back. Alcohol about 72 hours. Cannabis, no reported use. And tablet lorazepam, he has told that he has used about 12 hours back. So if I can open this for discussion, and if somebody wants to take a shot at inference and plan of these tests, now would be the time.
Yeah, I think it's interesting. So opioid is negative. What does it mean? You're saying there is pentazocine and heroin both. Right?
Heroin is 1 week back, pentazocine is ongoing.
That's interesting. So heroin 1 week back and pentazocine now. So any guess? You want to tell why it is so? So the opioid has come negative, but history-wise, heroin a week back and pentazocine continuing, correct?
Yes, about 2 hours back.
About 2 hours back.
And is an ongoing use.
Ongoing use.
With the audience like to know what type of test was done?
It's a point of care,
It's a
multi-drug test.
Cassette test.
Cassette test.
Test. Okay.
So what insurance is proton pump.
That is for opioids?
I think for cannabis.
Okay, right. Yeah, that's actually the fact. When we sent for cannabis levels, we didn't find any. So it was probably the pantoprazole which was doing some funny business.
I think it's very informative. You must be actively doing it. So it means people who are taking pantoprazole or omeprazole, you should take it cautiously, correct? It comes false positive.
Yes.
May not be all of them. But
not all of them.
Not all of
high
them.
chance of false positives you need to.
Similarly, when somebody's on HIV
It's
treatment
and
he's taking opioid, this is what happens in opioid treatment program. That becomes an issue.
That's interesting. What about opioid? I think heroin will not stay in the body for so long. This is my gut feeling. I mean, heroin will stay for 2 to 3 days max. Days that is faster. But and I think pentazocine is your protein. Pentazocine you're not able to pick up at all synthetic.
Yeah, we were not able to pick it, and then we sent a specific test. So basically, the inference for opioids is it's a false negative because you are testing for a compound which your test does not detect. So you have to send a GCMS confirmatory test for pentazocine. As I said, point of care tests only detect morphine. Morphine is not an intermediate of pentazocine metabolism, hence it wasn't detected. Benzodiazepines came out to be negative, same story. Lorazepam has to be tested separately. Lorazepam is not metabolized into nordiazepam or oxazepam for that matter. For cannabis, as all of you have already pointed out, it was a cross-reactivity of proton pump inhibitors. So as you see, tests did give results, and all those results were, in the lack of a better word, a googly. So, I mean, this is a rare case. Mostly, it's a quite straightforward use of UPTs. UDT, sorry. To wind up, UDT is not a diagnostic test for substance use disorder. Diagnosis of substance use disorder is based on history and corroborative evidence and things like that. It is certainly not a punishment. It's not a unilateral decision that you impose on the patient. It is not foolproof. So it requires some amount of understanding on the person, on the part of person who is ordering and interpreting it, and of course on the part of person who is doing it. It's not the end of therapeutic engagement. It is certainly not a one-time process. And sadly, so it is not as simple as UPT. I have got a lot of support from Dr. Priyamvada, who also happens to be here for any questions that you have.
So I think two things probably I just add on. The test he's talking about is point of care means a cassette test. I'll ask somebody to get a cassette, we'll show it. And the confirmatory test talking about GCMS and LS. Any question? I think Priyamvada take us on.
I think there are a couple of questions already. So, Dr. Jillur from Bangladesh has mentioned that in his country right now they are facing significant problems with amphetamine addiction. So, are there any tests that can be done at the bedside for amphetamines?
Cassettes are available for that, and that can be tested. In our population, we don't get much samples, much amphetamine. So, but ready-to-use solutions are available for testing amphetamine.
So what Dr. Priyamvada is telling Dr. Jillur, actually you can, like pregnancy kits, the kits are available, we pick which are either single kits or 6 drug kits. So we'll get a single kit of amphetamine also, we'll pick amphetamine only, or 6 unknown drugs, I mean 6 drugs like one is I think opioid.
Cannabis, opiates, opiate it will detect morphine and codeine only, then benzodiazepines, barbiturates, and cocaine, amphetamine. And that's all. And different combinations are available. You can go for 6 combination, you can go for 8 combinations, depending upon the patient
need of the clinician actually. So basically you can order the combinations and you get it. I mean it's not expensive. I think if you, I remember last couple of years back, 6 drug whole is 150 rupees, 150 to 180 rupees was the retail market of the 6 drug stuff, and single used to be some 50 to 60 bucks. I mean you can negotiate with the guy. But it's very useful when you look at like amphetamine, for example, amphetamine psychosis. We have a case recently, last couple of months back, because as you told, amphetamine, although are available in Bangalore, we know it, but unfortunately they're not coming to the treatment centers. So recently, one gentleman came with a very severe psychotic breakdown, acute onset, sudden onset psychotic positive symptoms. And that's the time we did the amphetamine, did the screen and actually got amphetamine positive. Because then we know that it's amphetamine induced intoxication, and he remitted on his own in a couple of days, and all right. So I think these are easy to do. So yeah. So and it reports comes immediately, is it not so? Report comes
There's a question from Dr. Sarah.
One of the adolescent boy, he brings some solution to mix up with the urine so that the cannabis is not detected. I don't know how you can manage that.
Like we have that adulteration testing device.
And it is available in the net, it seems.
Okay, like sample adulteration devices are available. So whenever it is we suspected any adulteration, at that time we test it. It is FDA approved, so it can detect if sample is being adulterated with
any other things.
Any other.
So it means people
are pH or creatinine level or anything like that.
No, like apart from that, adulteration strips are also available. So we can check for specific gravity and temperature and other, if any adulteration is there, change in pH, everything it can check.
Yeah, I mean,
and depending upon, and it's FDA approved, so it can check any adulteration if it is there in the sample.
Yes, so, madam, you can send that urine sample to us. We'll just find out. I mean, Priyamada is speaking. So, it's learning for me because I remember when I was in US, there's a big problem about the cannabis particularly, and that's why they use a synthetic cannabis. Because synthetic cannabis it cannot pick up in urine testing, and it's very harsh law in the so
Actually, this particular boy came from Nimmans only. He gave the whole report and he came and confessed to me that he gave me the site also where, which is the one, which is a very simple chemical which is available in any college or school lab, which he uses with that thing so that his test always comes negative. That is definitely to convince his mother, not in any other way.
Yeah, I mean, you want to it should be punitive or not? The question comes here, whether you want to behind the guy to prove or disprove.
One thing that we do is actually to portray the test as a confidence building measure in the sense that it allows a discussion. It allows the parent to stop being a policeman, and it allows the client to stop behaving like a thief. So in a sense, it allows people an objective measure. So one thing to do would be to talk to him that if everything is coming negative and his parent continues to suspect it, then she will go back to being extremely suspicious, checking through his things. Sometimes that itself, the fact that the parent will be less suspicious is a significant factor to actually go and try the test honestly.
Yeah, you can zoom the camera. I mean, somebody is there to zoom the camera. So I can show, this is a kit I'm talking about. Somebody can zoom the camera, I can show it. Yeah, the camera is not around. Okay, I can go near that. So, check in the camera. Okay. Okay.
No, you're not in the field. You'll have to come into the field. You'll have to
come to my field completely. Let me get the camera. Okay, I will let the camera person come. Is there? Yeah. You can zoom the camera. And how much you can see, I don't know, but we can keep it there. Somebody you can hold, somebody can hold and say it. I don't think it will be visible. Yeah, I think now it's fine. Or you can send snapshot and send to you. Yeah. Any questions you can ask? How can we procure? Okay. There's such another question, Priyamada, to you. How to procure the kits? He's asking.
Like there are these all are imported from US or US, so you have to search for a distributor, and through that only it can be procured. That they should have some specific license, and some authorized distributors are there, so through them we have to procure.
So can you pass this address to them, or client to go distributor address? They can contact directly and get it through. Is it possible? From our side, if you know some distributor name, later part we can give to them. They can connect directly and speak to them and get it. So I think what Dr. Priyamada is telling that, you can definitely get it. Probably she will pass the next email. You can pass the list of the distributors which are available. Again, you can choose from them and take it. Sorry, slide. Okay. Which of them is not? No, I think. Okay. Right. Any further question from here? Nobody is asking anything. For residents, for our so many people sitting around. Right. I mean, Priyamada, I want to tell something about GCMS.
Like here at toxicology laboratory of NIMS, we have developed different testing procedures. So like for drug of for alcohol, I'll start with alcohol. So in alcohol we can test ethanol, ethyl glucuronide, and ethyl sulfate that can be detected even the trace of alcohol is not in there. Then for toxic alcohol abuse, we can test formic acid, ethoxyacetic acid, methoxyacetic acid, and glycolic acid. Then for the solvents, also ready to use simple procedures we have developed where phenol and hippuric acid metabolites can be tested within 5 to 10 minutes. Then pain management panel is there in which about 10 to 12 opiate we can detect detect and quantitate. Same for benzodiazepines, around 12 we are trying to quantitate in a single run. And apart from that, like cannabis, synthetic cannabinoids, as well as that plant marijuana, we are able to test and quantify. Barbiturates and amphetamine, cocaine also we can test and quantify.
Yeah, one of the point I think she didn't speak about two things. Probably nicotine. She's recently standardized the in the biggest problem in our country, the different types of tobacco available, different brands, different company, different cigarettes, different brands. So she has actually quantified the concentration of nicotine in almost 40, 40, 50 brands, 70 brand international national companies of how much nicotine actually they contain. This is one part. You can Google and get her paper, or I can send to you. Second thing she didn't speak also is that one of the biggest challenges in alcohol to find out when is the last drink. And what she's talking about, by detecting urine ethylene glucuronide, you can find out till 72 hours. Am I right? Till 72 hours. Even the person has drank 72 hours back, still you will find the metabolite to find out what is the probably approximate time of a drink and stuff like that. So it is very useful for us, particularly in medical legal cases. When you have to give a certificate to bus conductor or bus driver, and so many people come around and ask. So these are biomarkers are very useful for at least alcohol and other things. Definitely other parameters are right. So I think any questions you want to ask, residents or anybody here, or in addition? Right. So two things. The two things we will do for you. I think we'll pass a small booklet on how to basically how to interpret the results and when to order a test. I will send the next email. We'll attest that one. That part I will do, and the second part we will do that.
I think there's one last question
Okay.
that has come in. If the patient lies about the amount of intake,
Yes.
can a test help in terms of
Yes.
quantitating the quantity?
Like if we go by that cassette test, then above cutoff it can detect how much quantity when it is taken by any method. It is difficult to quantitate. How much is present in the body can be detected.
Yeah, I think this point is how much is present in the body get detected. With alcohol, probably you can get some idea because for the zero order kinetics, we actually looking at how much metabolite is passing out. I remember some of the literatures are there where you can go back and tell, okay, probably this much amount of drink he has done, he has drank, and this how body metabolite is coming down. There are some studies, remember this is you did, they talk about some formula, but not for other drugs. It's impossible to find it. Okay, then let's stop here. I think we are before time there today. I think thanks to all of you for coming and logging in. Thanks a lot. Thanks a lot to hear the team here and Lekhansh, Soumya, and Anirudh. Thanks to. So again, next week we'll meet. Have 10-minute pre-break today. Thank you. Bye bye from our side.